Good morning. Good morning from New York, and good morning on behalf of Unetsis. I would like to welcome you for today's session. Today, we have the honor to have Professor Vincent Wong, who holds the position of the Mok King Yu Professor of Medicine and serves as the head of the Division of Gastroenterology and Hepatology at the Chinese University of Hong Kong. His research primarily revolves around viral hepatitis, steatotic liver disease, with a particular focus on the development and application of non-invasive tests for screening, diagnosis, and prognostications. Notably, he contributed to the writing committee responsible for formulating the guidelines of the Asia-Pacific Association for the Study of the Liver, the American Gastroenterological Association, and the European Association for the Study of the Liver. He has authored more than 650 publications in the international medical journals. His current H-index is 112. He holds the position of Associate Editor for the Journal of Hepatology and serves as an editorial board member for the renowned publications such as Gastroenterology, JHEP Reports, and Clinical and Molecular Hepatology. He was the president of the Hong Kong Association for the Study of the Liver Disease. And it's from 2015 to 2017. And currently he serves as the chairman of the Specialty Board of Gastroenterology and Hepatology at the Hong Kong College of Physicians. He has been honored with research awards from esteemed organizations such as MASLD, Asia Pacific Digestive Week Federation, British Society of Gastroenterology, Hong Kong College of Physicians, and the Health Bureau of Hong Kong SAR Government, and the Ministry of Science and Technology and the Ministry of Education of China. So with that introduction, I would like to welcome Professor Vincent Wong to deliver his talk, which is today. He's going to talk about non-invasive evaluation of hepatic steatosis, inflammation, and fibrosis, and recent advances. Over to you, Dr. Wong.
Thank you very much, Professor Steatosis, for your kind introduction. Good morning, ladies and gentlemen. First of all, I'd like to thank Unetsis for the opportunity to speak to you today. So I'm looking forward to our very lively discussion after my talk. So my focus today will be on non-invasive assessment, and here are my disclosures. So of course, since we are talking about steatosis, we are talking about steatotic liver disease. So this is a very famous publication by Dr. Mary Rinella and also colleagues talking about how we should classify and define steatotic liver disease. So under the new definition, steatotic liver disease is the umbrella term, and what we used to call non-alcoholic fatty liver disease is now called metabolic dysfunction associated steatotic liver disease, or MASLD. And of course, in fact, around 20 to 30% of patients with MASLD will have active disease, steatohepatitis, with active inflammation and tissue injury. On the other end of the spectrum, we also have people with alcohol-associated liver disease, so those who had liver disease because of excessive alcohol consumption. But what is important in this definition is the recognition that people can have both, so both metabolic risk factors as well as some degree of alcohol intake, and so the term MASLD, so MASLD with increased alcohol intake. We are interested in MASLD because it is very common. This is an updated systematic review and meta-analysis by Dr. Yunosi saying that nowadays more than 30% of the general population actually harbors MASLD. So it is equally high in most parts of the world with the exception of Africa, in which the prevalence might be a bit lower, but everywhere else we are talking about a prevalence of at least 25% and mostly over 30%. Now, apart from it being highly prevalent, another reason we are concerned about this disease is because, like many other chronic liver disease, it can also cause severe liver complications, including end-stage liver disease, as well as the development of liver cancer and decompensation. So again, these are data from Dr. Yunosi's group, so looking at the CS population. So here what you can see is that the green line depicts people with MASLD. Really, from the year 2002 to 2018, MASLD was really the only disease that increased rapidly as a cause of end-stage liver disease requiring liver transplantation. On the right-hand side would be the same figures, but normalized at the level in 2002. As you can see, the slope was really the highest among patients with MASH. So MASLD is again an umbrella term. So on one hand, we have people with simple steatosis, or what we call metabolic dysfunction associated steatotic liver. That is only fat accumulation in the liver without necro inflammation and tissue injury. So as mentioned, 20 to 30% of the patients with MASLD might have steatohepatitis, or what we call MASH. So here we start to see inflammatory cells, tissue injury, and then it would lead to progressive liver fibrosis, and finally to the stage of cirrhosis. And then, of course, the patient would be at risk of developing hepatic decompensation, HCC, and liver-related death. With this background, back to our title today, why should we assess steatosis, inflammation, and fibrosis? Now, steatosis is really the basis for us to diagnose steatotic liver disease, and as I will allude to a bit later, it also reflects the treatment response. Now, inflammation would indicate more active disease progression, and currently, it is the target population for clinical trial enrollment. Besides, whether or not the inflammation improves would also reflect treatment response. And finally, fibrosis is probably the most prognostic histological factor. So it would be closely associated with the development of cirrhosis and also its complications. Again, the degree of fibrosis is important for us to identify patients for trial enrollment, and it is also a marker of treatment response. Traditionally, we diagnose these features based on liver biopsy. So in fact, the NAFLD activity score proposed by the NASH CRN would be a numerical sum of the degree of steatosis, lobular inflammation, and hepatocyte ballooning. So all the key features of MASH. But of course, we know that liver biopsy has a lot of problems. So first of all, some patients may have contraindications to biopsy, including bleeding tendency and the presence of ascites. Even in good hands, complications can occur, including pain and also bleeding. And finally, or even more importantly, would be the issue of sampling error. So we used to think that liver biopsy is the gold standard for the assessment of the liver condition, except that it isn't. So in fact, there have been a number of studies talking about how unreliable liver biopsies can be. So this is a very classic paper. So at that time, Dr. Merriman and colleagues performed paired liver biopsies on the right and left lobes of the liver during bariatric surgery. By doing so, they could compare the two samples to see whether the histological features would agree with each other between the two samples. So from the bar charts, you can see that if you are only interested in steatosis, liver biopsy is not that bad, so the kappa is up to 88%. However, if you are interested in more prognostic parameters, including the degree of fibrosis and inflammation, the agreement was abysmal. As you can see, the kappa for the presence of hepatocyte ballooning, a defining feature of MASH, was only 20%. So meaning that if you take two biopsies, so in more than half of the cases, there would be inconsistency and disagreements. So before I talk about the individual parameters and individual tests, we also need to highlight that there are different uses for the NITs. So in many studies or in clinical use, we often talk about the diagnostic use. So it means that when you perform the test, you want to see whether there's any MASH or whether there's any fibrosis. So it is a cross-sectional assessment. You examine the patient at one point and you want to know the situation now. So theoretically, we can diagnose many things. We can diagnose steatosis, inflammation, and fibrosis, the focus of this talk, but we can also diagnose cirrhosis and portal hypertension. However, according to the FDA NIH biomarker working group, in fact, there are different kinds of non-invasive tests. And in the field of steatotic liver disease, we can also talk about prognostic marker. So this time, we still do the test in a cross-sectional manner. But what we want to do is to predict whether something will happen in the future. And that something can include the onset of cirrhosis, the development of portal hypertension, and major adverse liver outcomes, including decompensation and liver cancer. We also have monitoring biomarkers, so this time it is no longer cross-sectional. We are performing the test repeatedly over time, and what we want to tell is whether the disease is progressing or improving over time. So this is in fact what we clinicians do all the time. So we do not see the patient once, we will see the patient repeatedly. And therefore the meaning of the test over time, the changes, etc., would be very important. So on top of that, we also have response of pharmacodynamic biomarkers. So in my mind, this is actually quite similar to monitoring biomarker. The exception is that we are talking about the change while the patient is receiving treatment. So, um, so for example, it can be lifestyle intervention, it can be a drug for MASH, and now what you want to detect is whether there's improvement in steatosis, inflammation, and fibrosis. Now, of course, we can also look into improvement in more sinister conditions, including reversal of cirrhosis and also portal hypertension. Finally, we also have predictive biomarkers. So this time, you perform a biomarker test and you try to determine whether the patient would respond to a particular treatment or not. Now, I would say that it is desirable to have a single biomarker to fulfill all of these requirements. So, for example, in the field of diabetes, we have hemoglobin A1C, which you can use to diagnose diabetes. You can predict whether the patient would develop diabetic complications, and at the same time, you can also see whether the patient is responding to treatment and whether it is likely that you can reduce the risk of various diabetic complications. However, I would emphasize that at the end of the day, the accuracy and performance of the biomarkers would be more important. So if needed, you can have different biomarkers to serve different purposes. But of course, the holy grail is if you have one single marker that even primary care can use, that would streamline our care of patients with steatotic liver disease a lot. So at this moment, where are we in terms of NITs for steatotic liver disease? I would say that we have already got a lot of data on the biomarkers for diagnostic and prognostic purposes. However, I would highlight and show you that because the tests are still far from perfect, and therefore, if there are new biomarkers, we would still welcome that development. On the other hand, for monitoring, response prediction, and also predictive, I would say that it is still work in progress. First, let's talk about steatosis. This is the basis for the diagnosis of MASLD. So, hepatic steatosis can be detected by imaging, blood biomarkers or scores, or liver histology. However, in routine clinical practice, I would say that abdominal ultrasonography remains the primary test we use to diagnose the presence of hepatic steatosis. So this is a typical diagram indicating what a fatty liver would look like under ultrasonography. So the liver echo texture would be bright, particularly when compared with adjacent organs such as the right kidney and the spleen. At the same time, because the ultrasound energy would be dissipated more rapidly in a steatotic liver, and therefore there would be deep attenuation of the ultrasound signal. And finally, there would also be vascular blunting. So at the same time, apart from the detection of steatosis, we also need the presence of at least 1 out of 5 cardiometabolic risk factors in order to diagnose MASLD. Now, apart from abdominal ultrasonography, there are other non-invasive tests for hepatic steatosis. It can be something as simple as a prediction model. Now, in the literature, there are actually many different kinds of prediction models, but here, fatty liver index is one of the most commonly used in clinical studies, so it has also been more widely validated, and therefore I cite it as an example. So it is very easy to calculate, and nowadays, of course, we no longer use a pencil and paper. Instead, we can use various online platform or an app to calculate this. Fatty liver index is calculated through inputting the body mass index, waist circumference, gamma GT, and triglycerides of the patient. And then the model will tell you whether the patient is at high risk or low risk of having hepatic steatosis. Now, the advantage of using this kind of simple model is that it is inexpensive. One may even argue that many of the tests can be routine and therefore it doesn't cost you extra. And it is also possible to use this kind of scores to study epidemiology of steatotic liver disease in large retrospective registries, particularly when imaging is not available. So if you have a huge data set, you have lab parameters, but no imaging, you can use this to infer the epidemiology. However, there are also limitations that we should be aware of, so it is less helpful for the diagnosis in individual patients. It is also confounded by metabolic factors. So as you can see, we already have 3 cardiometabolic risk factors in this score. And therefore, if you show that fatty liver index is associated with adverse cardiovascular outcomes, for example, you really cannot determine whether the adverse outcomes are due to steatotic liver disease or the cardiometabolic risk factors. And this is something you cannot correct even using multivariable analysis. And finally, these factors are also confounded by treatment. So for example, triglycerides would be easily amenable to some lipid-lowering drugs, and therefore this may also affect how you interpret the findings. So in the clinic, another commonly performed test would be FibroScan, or the generic name would be vibration-controlled transient elastography. So we can measure 2 things using VCTE. So first of all, we measure the liver stiffness. So this is actually measuring the shear wave velocity as a reflection of the physical property of stiffness, and therefore it will reflect the degree of liver fibrosis. At the same time, the machine will simultaneously measure controlled attenuation parameter, or CAP. So remember, when I talk about ultrasound scan, I said that when the liver is steatotic, the deeper tissue would be blurred because of the attenuation of the ultrasound signal. And therefore, if you can measure the amplitude of the ultrasound signal and how fast it is dissipated across the liver parenchyma, you can estimate the degree of hepatic steatosis. And this is exactly what CAP does. So there have already been numerous studies talking about the diagnostic accuracy of CAP, and in fact, we also have a number of systematic reviews and meta-analysis. And these 2 are individual participant data meta-analysis indicating that either using the M or the XL probe for the measurement of CAP, the diagnostic accuracy is quite reasonable. So with an area under the ROC curve of around 80% or higher. So as you can see, with the XL probe, apparently a higher cutoff is required to make the same diagnosis. However, it turns out that CAP is not a perfect marker. So in fact, one problem is that it has a lot of variability. So if you measure CAP today and CAP tomorrow, there can be substantial variability. And therefore, the manufacturer of VCTE has proposed the Smart Exam module, including the continuous CAP. So unlike in the past, so when you using the older machine, you would measure CAP and liver stiffness by pressing the probe 10 times, and then you take the median value as reflecting steatosis and liver fibrosis. However, for continuous CAP, as long as you are putting the probe over the liver, it will start capturing the CAP values. So, and by doing so, by the end of 10 measurements, typically you would have more than 200 CAP measurements already taken. So as shown in this a collaborative work between our team and also our Japanese team, so we show that by using continuous CAP, you can substantially reduce the variability as reflected by the standard deviation of the CAP measurement. However, at the moment, in a cross-sectional manner, the continuous cap does not appear to improve the diagnostic accuracy further. So the interesting question is, in a cross-sectional manner, continuous cap may not mean much, but how about in a longitudinal manner? Would it be a more reliable monitoring test? Because if you can reduce the variability of the measurement, the changes over time may be more reliable. So this is indeed what we are trying to prove at the moment. So we have 150 patients undergoing lifestyle intervention, and we are using MRI-PDFF as the gold standard to detect whether a patient has improvement in the liver steatosis. And then we also use the MRI-PDFF response to determine whether a patient is likely to have histological benefits. And we are trying to compare with bedside abdominal ultrasonography and also VCTE using both the old cap and also continuous cap. So hopefully in 1 year or so, we should be able to show you more data on that. Currently, MRI is considered as the gold standard to measure hepatic steatosis. Using MRI, we have two techniques to measure hepatic steatosis. The first one is called MRI-PDFF, so which stands for proton density fraction. We also have proton MR spectroscopy. So as shown in some older studies, the two are basically interchangeable, so with very high level of reproducibility and also repeatability. However, because MRI-PDFF does not require additional software, and also it measures the entire liver, and therefore nowadays MRI-PDFF is considered the preferred option to measure hepatic steatosis. And therefore, when you read papers on the newer clinical trials, almost exclusively, we are using MRI-PDFF instead of MRS to measure steatosis. Why are we interested in MRI-PDFF? Except for the fact that it is very accurate and reliable. So this is thanks to Dr. Rohit Lumba's group. So through a series of studies, his group has been able to show that the MRI-PDFF response matters. So this is in relation to histological response. So this is a meta-analysis showing you that if a patient has a 30% or greater reduction in the liver fat content as measured by MRI-PDFF, the patient would be more likely to have a 2 points or greater reduction in the NAFLD activity score or to have MASH resolution. And outside the clinical trial setting, the same group has also demonstrated that the MRI-PDFF response would correlate with fibrosis improvement as well. Now, 30% is not a magic number, so this is the starting point where you can see some improvement in histology. So subsequent studies have also shown that if you have greater response, so for example, a 50% or even 80% relative reduction in MRI-PDFF, you are going to see super responders who would have dramatic response in the histology as well. Okay, so in clinical trials, we also have another new concept. So apart from the detection of MASH and also liver fibrosis, we have a concept called at-risk or high-risk MASH, which is defined as the presence of MASH, as defined as the presence of the MASLD activity score of 4 points or greater, with at least 1 point each in steatosis, lobular inflammation, and fibrosis. And at the same time, the patient should have F2 to F3 fibrosis. So why are we interested in at-risk MASH? The main reason is because most phase 2 and phase 3 clinical trials using paired liver biopsies would enroll such patients. So they are asking for patients who would have MASH and at the same time F2 to F3 fibrosis. And therefore, it is important to be able to diagnose this condition to effectively identify patients who may be suitable for clinical trials. To take one step further, one may also argue that if this is the way to identify or recruit patients in clinical trials, when a drug is registered, one may also use the same methods to diagnose the condition and also select patients for treatment. So this is an editorial I wrote together with Dr. Jimmy Lai. So this is a table summarizing the biomarkers for at-risk MASH. So this can be purely blood biomarkers, such as the NIS2 plus score or the NIS4 score, as well as the MAC3. So we can also have a combination of AST together with imaging biomarkers. The fast score would be the simplest, so we only need to perform VCTE, measure CAP, liver stiffness, together with AST. But there is a modified version using MRI, so the MASLD score is a combination of MR elastography, MRI-PDFF, and AST. And finally, Dr. Lumber's group proposed the MACFIB score, which essentially is a combination of FIB4 and MR elastography. So if we look at the overall accuracy, so as shown on this line, you will see that they are pretty similar. So one may argue that the fast score and MASLD score might be a cut better, but I would say on the whole they are pretty similar. So recently, our group has also proposed a blood-based biomarker panel for the diagnosis of MASH. So some of you may be familiar with a biomarker called cytokeratin 18 or CK18. So it was proposed by Dr. Ariel Feldstein many years ago. So showing that it correlates with the presence of hepatocyte apoptosis, which is also a feature of MASH. However, subsequent studies show that CK18 alone is actually not really that sensitive or specific for the diagnosis of MASH. And therefore, in this particular study, we show that the addition of 6CL10, or some people call that IP10, together with CK18 and body mass index would be much better in diagnosing MASH. So we used our data to proposed the panel, and subsequently the score was validated in independent cohorts in San Diego, Wenzhou, and also another cohort from Hong Kong. As you can see, the diagnosis of a MASH would be quite satisfactory. And importantly, if we want to assess whether MASH will improve over time, you can also see a very satisfactory area under the ROC curve of 86%. Now, the very interesting question now is, do we really need MASH biomarkers? So, earlier last year, so in fact, in March 2024, the first treatment for MASH was registered in the United States. So it is resmetirom, a thyroid hormone receptor beta agonist. Subsequently, the American Association published a white paper or guidance paper to talk about how to use resmetirom. One important thing is to use non-invasive tests to identify patients for treatment. So you can see that, so for in terms of the detection of significant fibrosis, ASLD proposed that you can either use liver histology, but you can also use non-invasive tests, such as a VCTE of over 8 kilopascal, or if you use MR elastography, over 3 kilopascal. At the same time, you may wish to exclude the presence of cirrhosis until resmetirom is proven to be effective and also safe in the cirrhotic population. Now, very interestingly, you would realize that the proposed algorithm is based on fibrosis biomarkers only, so not MASH biomarkers. Then the question is, what is the remaining role of MASH biomarker? So we know from longitudinal studies that MASH is correlated with adverse liver-related outcomes, but if you correct for the degree of fibrosis, it is no longer important. So this is a very famous paper by the late Dr. Paul Angulo. So he was able to show that as long as the patient has liver fibrosis or advanced fibrosis, the presence of MASH doesn't matter. So whether or not the patient fulfills the histological criteria for MASH did not have an impact on the prognosis. And in my mind, the only use of a MASH biomarker would be there if it can predict response to treatment. In other words, so if you have a new treatment like resmetirom, if you are able to prove that the drug works better if there is MASH, and it doesn't work as well if the patient does not have MASH even though there is fibrosis, then the diagnosis of MASH would be important. The trouble here is that in most clinical trials, we only included patients with MASH, and therefore whether a drug works differently in patients with low disease activity is currently unknown. It may be a very interesting question for subsequent real-world studies. So I have talked about steatosis, I have talked about inflammation, and I would focus more about fibrosis because it is really the histological feature that is associated most closely with adverse clinical outcomes. This is a meta-analysis by Dr. Rob Taylor. So he was able to show that indeed the fibrosis stage would be associated with increased all-cause mortality, liver-related mortality, the need for liver transplantation, and all liver events, including hepatic decompensation and also HCC. So if anything, we can still see that the risk will start to increase when the patient has F2 fibrosis. But as you may imagine, the risk would be increased in an exponential manner when a patient has bridging fibrosis or even cirrhosis. Again, back to simple fibrosis scores that all of us can use easily. So among the various simple fibrosis scores, I would say that we focus more on the FIB-4 index. So mainly because it is time honored, so it already has close to 20 years of history. And although many groups have tried to propose a new fibrosis scores, but time and again, it appears that FIB-4 is still among the best. So it is easily calculated through the input of age, liver enzymes, and also the platelet count. So similar to what I have demonstrated for the fatty liver index, the same thing holds true. So after inputting all the parameters, you would have an idea of whether the patient is having high risk of advanced fibrosis. So not only does the score have reasonable diagnostic accuracy for advanced fibrosis, it can also be used to predict liver-related outcomes. So this is a Swedish general population study. So what distinguishes this paper from others is that the investigators looked into not only one but also serial FIB-4 index. As you may imagine, people with persistently high FIB-4 index would have the higher risk of liver-related outcomes. In this study, defined as incident cirrhosis, liver failure, liver cancer, transplantation, decompensated liver disease, and liver-related death. And people with persistently low FIB-4 index would have the lowest risk. However, what this study adds is that people with increasing FIB-4 index over time will still have intermediate risk of developing adverse outcomes. So this gives meaning as a monitoring biomarker. Although I said that there have been limited advancement in this field, but in the past 1 to 2 years alone, there have been some other proposed risk scores with different purposes. So this is the liver risk score. Multi-center design, our group was lucky to be involved. So the study design is very interesting. So the investigators first used a big fibroscan cohort. So use the liver stiffness as the reference standard to derive the score. Subsequently, the score was validated in the UK Biobank to predict clinical outcomes. So as you can see, the risk score tracked very well with the liver stiffness measurement, and importantly, it is also prognostic. So by dividing the patients into minimal risk, low, medium, and high risk, you can see from the Kaplan-Meier curves that we can really have distinguishing liver-related mortality. So another score was only published earlier this year by the Danish group. So they used a machine learning model to involve age together with 3 to 9 variables. So including liver enzymes, INR, albumin, sodium, bilirubin, platelet count, and also cholesterol. What is interesting in this score is that you do not need to have all 9 laboratory variables. So this is to mimic the real world. So particularly in primary care setting, or if you retrospectively looked into our registry, some patients may have several of the parameters, but not the whole panel. But the score can take care of those missing values. So whether or not you have 3 or 9 laboratory values, you can still calculate the liver pro score. Of course, if you have more variables, the prediction would be more accurate. But even if you only have 3 of the parameters, it doesn't hurt either. So again, you can see that the score is prognostic. So you can predict not only liver-related events, but also mortality. So after talking about the simple fibrosis scores, next, let's talk about VCTE. So as mentioned, apart from CAP for steatosis, we also have a liver stiffness measurement for liver fibrosis. In order to establish VCTE as a potential monitoring tool, our group convened a multi-center study called the VCTE Prognosis Study. So this study included close to 18,000 patients with MASLD who had undergone VCTE from 16 centers, and the data were prospectively collected from 14 centers. So the majority of the patients were from Asia, but we also have a sizable cohort from Europe and the United States. So this is the study design. So we included those patients who had a VCT examination, and whenever possible, we try to collect serial VCT examination. So we excluded patients who had liver-related events before the first VCTE or between the VCT examinations between 6 to 60 months. So this is the study design. So if the patient has several VCT examinations within the first 5 years, we try to pick the first one as well as the last one to look into the prognostic significance of a change in a VCT examination. And in this study, liver-related events were defined as hepatic decompensation, HCC, liver transplantation, or liver-related death. So what we showed first was that according to the scores, the most prognostic. The actual scores combined not only fibroscan parameters, but also platelet count, liver enzymes, and also the presence of diabetes, the sex and age of the patient. Now, there is some improvement in the overall diagnostic accuracy for both F3 and also F4 disease. However, one of the most important contributions of the actual scores is that it classified fewer patients into the gray zone. As you can see, for the HL3 plus score, down from 28% for FIB4, 24% for LSM alone to 17% if you use the HL3 plus score. The same holds true if your target is to detect cirrhosis. So next, we looked into the prognostic meaning in the agile scores. First of all, people tend to have stable agile scores over time. So in fact, 80% of the patients would have stable agile 3 plus score, and over 90% of the patients would have stable agile 4 score over 2 time points. And the Sankey plot would tell you that a minority of patients would nonetheless have shifting in the agile scores over time. And indeed, the change turns out to be prognostic, particularly for patients who had intermediate risk or high risk based on the actual scores at baseline. A change in the score over time would translate into a change into the risk of liver-related events as well. So apart from talk about category changes, we can also talk about percentage change. So again, if there is a 20% or 30% greater reduction or increase in the HR scores, you can also see concomitant changes in the risk of liver-related events. What if you find the calculation of the HR scores cumbersome and therefore you only want to look into the liver stiffness? Again, you can see that the change in liver stiffness over time is also prognostic. In particular, if the patient has a baseline LSM of 10 to 15 kilopascal and there is a 30% or greater reduction in the LSM, there would be a tenfold or more reduction in the risk of liver complications. In contrast, if there is a 30% or greater increase in LSM, it would translate into roughly double the risk of liver-related events, both in patients with intermediate and high LSM at baseline. In contrast, because people with low LSM at baseline would be at low risk anyway, and also a 30% increase in LSM in someone with very low LSM may not be that important. So, and as you can see, the changes in the liver-related events is also less apparent. So this is another lesson. So when you try to look into changes in any biomarker, the baseline value also counts. So if the baseline value is low, usually we are talking about a low risk population, and therefore the changes over time would carry less prognostic significance, particularly if the interval is not that long. But of course, if you are talking about 10 years, 20 years time frame, then I'm quite sure that the increase in the biomarkers would be prognostic. So apart from VCTE, we also have MR elastography, which is currently one of the most accurate method to measure liver stiffness and liver fibrosis. And therefore, not surprisingly, it is also prognostic. So, however, because we have many more patients who had undergone VCTE than MR elastography, currently the data are still scarce. So this is one very good meta-analysis combining 6 studies indicating that if the the liver stiffness by MRE exceeds 5 kilopascal, you can already see an 11-fold increase in the risk of liver complications. And if it is over 8 kilopascal, then you can see an even greater increase in the hazard ratio of hepatic decompensation. So how about the change in MR elastography? Here, we are seeing even a lesser degree of evidence. So this is from Dr. Elena Allen's group. So as you can see, the change in MR elastography appears to correlate with the incidence of cirrhosis, decompensation, and death. However, I must emphasize that we still need to gather more data. As you can see, the number at risk in the high-risk group is only 7 patients. So you can imagine that the estimation of the risk can be highly inaccurate. Now, we have been talking about different biomarkers. However, this is not what the guidelines are asking us to do. So currently, the guidelines are converging to the same kind of recommendation on the use of NITs to assess patients with MASLD. So they typically would ask people to perform a simple fibrosis score, most typically FIB4 as the first step. So only when the score is abnormal or intermediate risk would people undergo the second line test, such as VCTE, MR elastography, or a blood biomarker. And then you can further stratify the risk. So the reason is because we have to accept that the majority of patients with MASLD are not seen in hepatology clinics. They are seen in primary care instead. And therefore, we have to consider the availability of the test and also the cost of the test. And because of that, we conducted a study recently published in the Journal of Hepatology, validating that this kind of two-step approach is actually also prognostic. And interestingly, if FIB4 is used as the first line test, the use of agile scores instead of LSM as the second line test are similar. So you cannot improve the prognostication further by using the Agile score. This is not too difficult to understand because there are some variables in FIB4 that are also in Agile scores. And because of the overlap, then if you have already performed the FIB4 score, then you may not need to consider the additional parameters. And interestingly, we also show that if you reserve LSM for patients with intermediate FIB4, the prognostication is equally good compared with if you perform LSM for every MASLD patient. And therefore, this in a way would support the current guideline recommendation. And on the other hand, this would also be cost saving because you do not need a second line test for all the patients with MASLD. Now, whenever you perform two tests, there is a risk of discrepant results. So how would that pan out if we talk about FIB4 and VCTE? So this is what we looked into as well. So we presented the data at the last ASLD meeting in San Diego. So we realized that the majority of patients would still have both low FIB4 and also low LSM. So, and however, around 1/3 of the patients would have discrepancy between FIB4 and VCTE. So on the right-hand side, we show data on how we should interpret the data and the meaning of the discrepancy. If your focus is on histological F3 and F4 fibrosis, then of course, people with both high FIB4 and high LSM would be most likely to have advanced fibrosis. However, if the tests are discrepant, then still LSM is more accurate because people with low FIB4 and high LSM, 30% will still have advanced fibrosis compared with 15% if it is the other way around. However, what is more reassuring is that when the two tests are discrepant, very low number of patients would develop liver-related events in the next 5 years. So meaning that if you have discrepant results and for one reason or the other, you are only performing one test and therefore you missed those patients, it may not matter as much in the short term because those patients are not going to develop liver-related events in the short term. So I would say that based on this, we can still follow the current guideline recommendation of the two-step approach. However, there are always caveats, and one of the caveats is that the prediction for hepatic decompensation is better than our prediction for HCC. So again, this is based on our VCTE prognosis study. So in the middle would be the prediction for decompensation. As you can see, for histology, Agile score, LSM, as well as the simple fibrosis score, we are talking about quite decent area under the ROC curve to predict decompensation. And on the whole, the prediction is worse when we are talking about HCC. This is not surprising because we know that there is a phenomenon called non-cirrhotic HCC among patients with MASLD. So this is from Dr. El-Sarek and Dr. Fasiha Kanwal's group from Baylor. So what they did would be to analyze the VA cohort data, and they divided the patients into different etiologies. So the blue bars would indicate the proportion of patients who developed HCC, but they didn't have cirrhosis. So interestingly, we used to think that the hepatitis B virus is directly carcinogenic, and therefore we recognize that some patients can have non-cirrhotic cirrhosis. However, in this particular study, they demonstrated that indeed MASLD would be the disease with the highest proportion of patients having non-cirrhotic HCC. And therefore, if you only rely on a fibrosis biomarker, you are going to miss some patients with HCC. Then what can we do? So the obvious solution would be to identify other risk factors and also derive new tools to do that. And therefore, our group, in collaboration with several other groups, derived and validated the SMART HCC score. So we published that last year. So this is based on LSM, etiology, as well as various demographic and laboratory parameters. So as you can see, now we can quite safely exclude patients at low risk of developing HCC, regardless of etiology, including the presence of MASLD. Now, finally, I would like to talk about the Achilles heel of the current NITs. So one main problem is that we do not have very good pharmacodynamic or response biomarker. So this is our secondary analysis of the REGENERATE study by Dr. Mary Rinella. So as you can see, if the patient is responding to obeticholic acid, so with improvement in the liver fibrosis, you can see that the NITs tend to improve as well. FIB-4 index come down, ELF came down, and liver stiffness as well. However, in this particular study, the investigators only looked into the trend and did not really scrutinize the accuracy of those tests as a monitoring or as a response biomarker. So 2 years ago, we also looked into the phase 2 semaglutide data. And in particular, we were interested in the FAST score, which is a biomarker for at-risk MASH. So we hypothesized that this may be used to determine whether a patient would have resolution of MASH. So as you can see, once a patient was put on semaglutide as compared with a placebo as depicted by the yellow line, there is a dose-response relationship in terms of a reduction in the FAST score. And in fact, all three components of the FAST score, the AST, CAP, and also liver stiffness, came down while the patient was on semaglutide. So if anything, the longer you treat the patient, the greater the reduction would be. On top of that, we also showed that patients who had improvement in the FAST score were also more likely to have resolution of MASH without worsening of fibrosis, as well as improvement in the NAFLD activity score. However, I would like to emphasize that the area under the ROC curve for a change in the FAST score in predicting this histological response is only in the range of 60 to 70%. So the association is certainly there, but whether it is precise enough for you to tell whether a patient is improving or not, I think there is still room for improvement. So finally, let's talk about the implementation of this kind of clinical care pathway. So I have talked about the two-step approach for the diagnosis of advanced or significant fibrosis. And some of these clinical care pathways have been tested in clinical research settings. So for example, this is the Camden and Islington pathway conducted in the UK. And what the investigators showed was that in GP settings, you can apply this kind of pathways and still reduce unnecessary referrals by 80% and increase the detection of advanced fibrosis by 5-fold, cirrhosis by 3-fold. However, I would argue that this kind of pathways might be implemented in clinical trials. However, if you want it to be consistently and broadly applied in clinical practice, it is not easy because our primary care physicians have a lot of competing priorities. And therefore, 2 years ago, we published another RCT to test the implementation of this kind of clinical care pathways. So half of the patients had usual care, and half of the patients had the fibrosis score, including FIB-4 calculated based on the existing lab values. And if the FIB-4 is abnormal, there would be an electronic reminder messages every time a clinician logged into the system. So what we showed was that there is a 10-fold increase in the referral of patients with abnormal FIB-4. However, this is still far from perfect because we are only talking about 30%. More than half of the patients still, despite abnormal FIB-4, were ignored. So in summary, ladies and gentlemen, I have shown you that many of the NITs have already had proven diagnostic accuracy, and they are also prognostic. If anything, the prognostic performance is similar to that of liver histology. I have also shown you that changes in the FIB-4 as well as the liver stiffness measurement by VCTE and possibly MR elastography can also correlate with adverse clinical outcomes. However, whether we have biomarkers to determine whether a patient is responding to treatment, and finally, our holy grail of developing surrogate endpoints for clinical trials so that our poor patients no longer need to undergo repeated liver biopsies to demonstrate the efficacy of a drug. This is something we should work together to improve upon. With that, I thank you very much.